Okay. So we've maintained blood flow. By either pumping harder with the heart, or in terms of what we talked about today, maintaining constant blood flow with vasoconstriction. This leads us into blood pressure. We can measure blood pressure. We can measure pulse rate. We can measure a multitude of things to help us to understand if our heart is effective, if our blood vessels are effective. And that's really where blood pressure comes in. Obviously, blood pressure is the amount of force against the blood vessel wall, okay? Due to, again, the heart or the blood vessels. We can determine a blood pressure gradient. We can determine a pulse rate. We can determine a pulse pressure. We can determine systolic and diastolic various types of pressures. All of these types of pressures or pressure gradients allow us to figure out if intervention is needed. Is their blood pressure high? Intervention is needed. This concept of blood pressure gradient. Blood pressure gradient is how blood moves through the system. Okay. At one end of the vessel, it's really high. At one end of the vessel, it's really low. Okay. So where does stuff move? Stuff moves from high to low. So here where it's really high, it's going to move towards where it's really low. Makes sense, right? So it's going to be highest in the arterial tree, lowest in the venous side. Not a lot of pressure there because the heart is pushing all of its force to get to the capillary. Once it gets to the capillary, it's done. That's what blood pressure gradient is. Arterial blood pressure, I think you know. I mean, it's just check the pulse. It's the highest pressure that's basically within the arteries. This is the ones that are getting the stretched. These are the ones that are getting the stretched from the heart because the heart is what's pushing and generating all the force. And it's your upper number, right? It's your 120 millimeters of mercury. Diastolic pressure is the pressure that's generated within the arteries when the ventricles relax. Diastole, right? We talked about this the other day. And it's your bottom number. And 120 over 80 is the number that you want to stay below. It's not normal blood pressure anymore. I believe it's like 125 over 75. So basically anything under 120 over 80 is considered really good. 120 over 80, not necessarily ideal anymore. Anything above 120 over 80, and then you're getting to the semantics of whether or not they're calling it hypertension type 1, 2, or whatever they come up with anymore. The difference between systole and diastole is referred to as pulse pressure. It is the difference between systolic and diastolic, the difference between the heart contracting and the heart relaxing. Pulse pressure is important because it can give you some ideas of disease or some potential diseases going on. And really the big one is going to be high blood pressure, but there's a number of other diseases that, a high or low pulse pressure can be indicative of. And we're not going to get into that. You'll do it in pathophys later on. But for us, it looks at the elasticity. How much stretch can these blood vessels do? Can these arteries do? If you have a nice strong pulse, nice good pulse, you have a good pulsability to those arteries, then 120/80 and subtract it, and there you go. It's around 40 millimeters of mercury is your pulse pressure. A little bit higher, okay, now we have to start doing some intervention or some potential looking into. Is it high blood pressure? Is it you're anxious, nervous? Did you just get done walking a flight of stairs, walking down the hallway? Now you have to try to figure out, is it because of situations or is it because of some kind of issue? With age, pulse pressure drops down, so this is going to be much different number if you are somebody who's 30 compared to somebody who's like 80. And they use pulse pressure and they use blood pressure and they use oxygenation rate to determine if you're healthy or not from a cardiovascular standpoint. And do you need medical intervention? So kind of understanding that it represents the degree of elasticity, I guess, is the important concept. I'm not going to ask anything more about it than a multiple choice question. I know it's been asked of what it is on the NCLEX. So I do know that it's been asked in the past. So from that standpoint, understanding what pulse pressure is generally about all I ask, okay? Because that's all that's generally asked on nursing type board exams. How do you measure blood pressure? You know it. A sphygmomanometer there, listening to the different Kharkov sounds. Blood wrapped around that brachial artery right there, and compress it till you hear nothing in your stethoscope. Slowly open that blood pressure cuff back up. And then you'll hear that first sound. That's your systolic number. To overcome the pressure exerted by the heart, to overcome that pulse or that pressure exerted by the cuff. And then the last sound you hear is when the blood vessel returns to its normal state and no sound is heard. So when you hear that last sound, that's your diastolic number. And again, 120/80 is generally considered, 120 or below is generally considered ideal. And you should know 120/80 for blood pressure, going no higher than those. We do this on the arterial side of the tree just because that's where all the pressure is. Okay. That's where all the pressure is. So if you know somebody's blood pressure, then you can easily determine pulse pressure. Okay, if you found their pulse, found their blood pressure, okay, determine that to be 120/80 because that's just easy math, and figure that to be 40 millimeters of mercury. Awesome. Blood pressure and pulse pressure, these are things that now we can use. These are two things that we can use because, like I said, we can determine how healthy the individual is. We can determine how much oxygen is ultimately being pushed to structures, tissues, organs. And we can measure how much oxygen is getting sent to your quadriceps femoris muscle. We can figure out how much is going to the brain. We could do that because now I can throw these numbers in a mathematical equation. And I know I said the M word. I apologize. I don't want to do this to you, but I'm going to. And that is MAP. MAP is mean arterial pressure. Mean arterial pressure is the average blood pressure across the entire cardiac cycle. Not just when I cut the dang thing off and open it back up. Mean arterial pressure gives me a great idea of this word I keep saying, perfusion. How much blood is being delivered into those structures? If I don't have enough blood going into a structure, then what do I not have a lot of? I don't have a lot of what?
Oxygen.
Oxygen. Perfect. Nutrients. That would have been another one somebody could have said, but oxygen is what I'm talking about. And here, if my blood pressure is 120 over 80, I mean, there it is. MAP equals diastolic pressure. Okay. Plus 1/3 the pulse pressure. So 40 divided by 3. And that gives me a mean arterial pressure, which is telling me I have very good perfusion. Anything less than 60, that's when you get really worried. And I think anything over, oh my gosh, what's the number? Anything over 100, 110, 120. I can't remember off the top of my head. Anything less than 60 is really bad. Why is that really bad? Because this ensures that you're not getting enough blood flow at all. And if you're not getting enough blood flow to the brain, the body does a great job of hitting the reset button on you, getting you to pass out. You pass out, you wake up, and your body has basically reset itself. Okay? Or you hope it has anyway. It usually does. Okay? Gets the vasoconstrictors back to working and gets blood going to the brain effectively. So anything less than 60, and that's what that means there, a MAP less than 60, that indicates insufficient blood flow. So you're not getting enough oxygen and you can't maintain anything. If it's over like 110, I want to say 110 off the top of my head. If it's over 110, then that usually causes edema, and really cerebral edema is what I'm more worried about. If I have severe compression of fluid within the brain, I'm going to have a lot of issues there. Misfirings. It's just not a good situation. Got to relieve the pressure, right? And so, cutting open my head would be the way that I would do that, and I really don't want to do that. It doesn't sound like a fun day. Okay. But understanding pulse pressure and what is your blood pressure allows me to determine what MAP is. And what is MAP? MAP is telling me how much oxygen, it's telling me how much blood is coming into a structure during each heart cycle. Contract, contract, contract. How much blood is getting into the tissues with every contraction. And if it's really, really low, less than 60, you're in a world of hurt. I may ask you to calculate MAP. I may put a question on the exam. I don't know. I haven't made the exam up yet, so I don't really know. Okay? But understanding what MAP is, telling you how much blood is getting to tissues, i.e. how much oxygen. Okay, how do I figure it out? Those would be good questions to know. The last couple things here, guys, and then we'll stop for the day. Um, 160, 110, 160. If MAP is over 160, that would cause cerebral edema. That would cause an excessive amount of fluid accumulation throughout the body. It's 160. So let me write that over here. Okay. If it's 160 or higher, cerebral edema. Okay, cerebral edema. Excessive fluid accumulation. And where would it be the most detrimental? In the cranial vault. I don't really want to say anything here about capillary blood pressure. It's negligible. It's super low. Why is it super low? Because it's one layer thick. There's some pressure on one side, a little bit less on the opposite side, but I don't really want to say anything more than that because I think we've talked about that phenomena, hydrostatic pressure, colloid osmotic pressure. What I do want you to know is how in the hell do I get this blood to keep going forward through the system? If all the pressure is on the arterial side of the tree, how in God's name do I get this blood to continue to move forward through the system? Two major ways. Well, three major ways. Valves, which we already talked about. Skeletal muscle contraction, which is on this slide. And this thing called, let me know if you haven't heard of this, breathing. All of these blood vessels, arteries, veins, traveling around all around the body through various different compartments. These are the same compartments that house muscles, skeletal muscles, smooth muscles, muscles. And if we were able to look at some of these things, well, in the dissected images on APR, you can kind of get an idea when you start looking at these blood vessels. These things run right along top of muscles, skeletal muscles, smooth muscle. And so anytime a muscle contracts, it's going to push against those blood vessels. So what do we have on the venous side to ensure that blood moves forward through the system? Well, the biggest one is going to be valves. And you see that right here. Okay, here's our valves. It ensures one-way flow going forward through the system. And it's not letting it go back. Why? Because just like those semilunar cusp, blood fills the cusp, shuts the door, and blood doesn't go backwards. Number two, skeletal muscle pump. Okay. Skeletal muscle pump. As muscles contract, those veins get squeezed, and that helps to push fluid forward through the system. We already know that I can be sitting here and muscles can be contracting, right? Helping to maintain my upright posture. So there's already some muscle activity occurring even though I'm not really moving. We've already discussed that phenomena earlier with skeletal muscle. So when these muscles contract a little bit just to maintain upright posture, you're helping to push fluid forward through the system. Now, start moving around and, now I'm shucking and jiving and now I'm really pushing fluid forward through the system. But what am I also doing? Increasing metabolic demand. So I'm going to have more blood being delivered to that muscle. And thank God I have all this skeletal muscle activity pushing all that blood back towards the heart so I can get it reoxygenated and get it out. It's also why blood pools in your legs, guys, when you're really inactive. Inactivity, no skeletal muscle contraction, or negligible, plus the power of gravity, blood stays down in the legs a little bit longer. So fidgeting and moving around helps to get that blood moving back towards the heart. Skeletal muscle pump. Number three, respiratory pump. You ever been to a hospital, right? You guys have all been to the hospital, I assume. If you stay in the hospital, you're laying in that bed for a lot of time. Do they let you, get up and move around a whole hell of a lot? Not a lot. Maybe a little bit of movement when you can. But what if you're bedridden? You can't move around. How do they keep fluid moving? Because what's the one thing we don't want? We don't want bed sores, right? We don't want bed sores. You don't want that pooling of blood in one little region of the body there because it's going to cause some bed sores. So what do? You know that little thing they breathe into, and it's got the little ping pong ball in it, and you can get it to flutter up and down by breathing into it. That little thing allows us to increase the volume in our thoracic cage. By increasing the space, the volume of my thoracic cavity here, when I take a deep breath in, I'm opening up blood vessels, and then now I'm compressing it as I exhale. And that's squishing those little veins, squishing those big veins, squishing those medium veins as they're getting closer and closer back towards the heart, helping to push fluid through the system. Not only does it do it up there, but when you breathe, take a big breath in, guys, and blow it all out. Keep blowing, keep blowing. What kind of kept going in? Your abdominal region, right? So that really compressed those abdominal regions as well. So you're moving blood forward through the veins, of that abdominal region as well. So this inspiration and expiration helps you to really push fluid forward through the system. So just the simple concept of breathing, guys, which you're all doing right now, helps to move fluid forward through the system. And that's one of the concepts that they utilize inside a hospital with that little breathing device. Okay, that's why did you do your breaths today? It ensures that fluid keeps to moving, doesn't get stagnant, and doesn't invite disease. What if valves become non-functional? Are valves forever? Valves are not forever. If the valves become non-functional, then you know it. It's called a varicose vein. That's where this valve becomes non-functional. So this guy doesn't work anymore. So blood can go back further. And these are your spider veins, right? Those are varicose veins. The most classic example of a varicose vein is a hemorrhoid. If you sit too much, stand on hard concrete too much, strain at the toilet when you're going poop too much, you can increase intra-abdominal pressure, and that can cause those three little veins down there, not necessarily all of them, but you can cause one of those three little veins down in your anus to blow out. And unfortunately, that is called hemorrhoids. Pregnancy can cause it. Obviously, you're growing a creature inside of you and it's weighing down on you. But that's what a hemorrhoid is. Okay. A non-functional valve within the veins of the anal rectal region. And you have three of them down there. So you can have upwards of 3. Life sucks when that happens. But, you can do the laser treatment on them and get them taken care of pretty easily. Okay? Pretty easily. If you have 3, hemorrhoids down there, that stinks. You're always going to have one. You got to have blood flow returning from at least one of those blood vessels down there, or you're going to lose the tissue.